Village's Vitality listeners, I've got some good news for you. In Season 8, most new episodes were released as both audio and video versions. Videos on Apple Podcasts, Buzzsprout, and YouTube. If you're listening via our Buzzsprout feed, you can ask questions via the fan mail button, or leave me comments as a text, or in our new feature, you can send it as a voicemail. If you'd like a response, make sure you leave your name, email address, and cell phone number.
Welcome to Season 8 of Village's Vitality Life, Seniors Life Unscripted. In this new season, we talk to leaders of clubs and interesting folks who live in and around the villages. We also talk to people who have information vital to seniors. You will get perspectives of what is happening in and around the villages, Florida. In addition, we will add more information for all seniors.
This is Mike Roth on Village's Vitality, Senior Life Unscripted. Today I have a very special guest, Dr. Stephen Scionti, a board-certified urologist who specializes in prostate cancer treatment and a founder of the Scionti Prostate Center. He offers comprehensive diagnostic services, including MRI fusion, targeted prostate biopsy, and MRI-guided targeted focal treatment of prostate cancer. Thanks for joining me, Dr. Scionti. How is prostate cancer diagnosed?
My prostate cancer diagnosis starts with getting the PSA blood test. That's the first step. And they go to a screening, but usually as part of an annual physical, a man has a blood test called a PSA. And the PSA reflects the degree of activity within the prostate. If that PSA number is abnormal, that will prompt more investigation. Okay, so that's the first step though. Once the PSA is elevated, I'm always going to recommend an MRI study of the prostate. So an MRI is an imaging test in which the prostate can be seen in great detail, and areas that have a cancer will show up very nicely on MRI. And so the decision about whether a man needs a prostate biopsy or not starts with an elevated PSA and an MRI study. Now, the MRI shows whether the prostate's enlarged, because an enlarged prostate may be a cause of an elevated PSA. If there is an area, if there's a cancer, though, that will show up nicely on the MRI and will tell the urologist that the next step would be a prostate biopsy.
Now, the PSA test has been around for a long time. False positives in the past, even a tendency to not offer a PSA test to men over 75. Do you think that's wrong?
I think it depends on the age of the man, and that's a conversation that doctors got to have with the patient. I've got a lot of 75-year-olds they're like 50-year-olds, right? They got 10, 15-year life expectancy and they have prostate cancer, we'd probably want to know about it. On the other hand, we have gentlemen who are 75 who are with a lot of medical problems, and it's probably not as important. But that's a discussion with the doctor. But I don't believe there should not be an age cutoff strictly. It's really a shared decision made between the doctor and the patient.
How high of a prostate test number does someone have to have before they should be considered worrisome?
The number really depends on prostate size. And the old adage that a PSA over 4 is too high, that really depends on the size of the prostate. But in general, if there's a PSA that for the typical, say, 70-year-old man, if the PSA is over 4, at least the PSA should be monitored carefully. And if it keeps on rising, then the next step is to take a look at the prostate with an MRI study. So the days, I think, there's a tendency still for this reflex approach. PSA is elevated, let's just do a biopsy on a patient. I think that's old-fashioned, and I don't think that's correct. Today's technology allows for much better precision diagnostics. By getting that MRI, we can determine whether a man really needs a biopsy or not. And if a man does need a biopsy, the MRI becomes the roadmap. It's the roadmap as to how to direct the biopsy. So biopsies are done into the prostate via what's called a needle biopsy. My preference is to use what's called a transperineal approach, which means We no longer put needles through the rectum into the prostate. So I've gotten away from what's called a transrectal prostate biopsy because of real infection issues and bleeding it can cause in the rectum. The modern technology is to take a biopsy through the perineal skin. That's that patch of skin that's down kind of where you sit on a bicycle seat. It's that patch of skin between the scrotal area and the rectal canal. Now, here's the key with this, is that if the MRI shows an abnormality, software is used to create a 3D model of the prostate. That 3D model of the prostate is integrated to an ultrasound picture, and now the biopsy becomes targeted, not random, right?
Yeah.
Can you imagine going fishing without a fish finder, right? Or going hunting without aiming, right? That's what a random biopsy is, right? So a targeted biopsy is using the MRI roadmap to direct a biopsy needle directly to where the abnormality is. And that precision in diagnostics allows for a much more accurate ability to understand whether a man has cancer or not. And if there's a cancer, how aggressive is the cancer, right? If the needle doesn't capture the tumor, then we miss the whole thing and we don't know what we're dealing with.
What do you see differently on it in MRI that tells you it's cancer?
The tumor region looks very different, right? The MRI has different ways to look at the tissue, right? There's a series of images that are, not to get too technical, but there's something called the T2 image, and the tumor is going to appear as a dark spot, okay? There's another way the MRI looks at that. It looks at the way water moves through the prostate tissues. That's called diffusion. And so if there's restricted water movement, that shows up as a bright spot on the MRI. And those are signs that there may be a cancer present in that area.
Now you said that you create a 3D model of the prostate.
Yeah, that's called fusion, right? And so what that is, it's using computer software to overlay the MRI picture to the ultrasound picture, right? And then we see exactly, using ultrasound technology with the MRI overlaid to it, where that suspicious area is. So that allows then for a biopsy needle to be tracked directly to where the abnormality is.
That makes a lot more sense than the random placement of 12 samples.
I've been doing targeted biopsies since 2012. I was very much involved in the early phase of that. But I will tell guys out there that be careful, because there's still some urologists that still do the old-fashioned random, non-guided biopsy. So it always helps to ask. When the doctor says you need a biopsy, ask, how are you going to do it? Are you going to use the MRI to guide it? Are you going to use software to help guide that biopsy?
But the worst case is you discover some prostate cancer. What are the treatment options today that you recommend for patients?
Prostate cancer comes in all sizes and shapes and flavors, right? So you can have these very small, very slow-growing prostate tumors that will probably never be dangerous, right? And that's called a low-risk prostate cancer. If someone's got a low-risk prostate cancer and they're 70 or 75 years old, then they're likely never going to need treatment. So we put those men on a monitoring, or what's called the surveillance process, right? So a lot of men don't need treatment. They just need to be monitored. And they'll never come to any harm with that. The next step up, though, sometimes we see these tumors that are in a region, an area of the prostate, and it's got the characteristics of a more active cancer that's got the ability to grow and spread if we leave it alone. And if that's regional, if that's in an area, then we have advanced techniques to just treat the bad spot. So instead of destroying the entire prostate, the bad region can be treated. That's called focal therapy. It's a targeted treatment to the tumor region of the prostate, but preserving as much normal prostate as we can preserve. And why that's important, because preserving prostate tissue preserves function, preserves urinary function, preserves erectile function, right? Sometimes it's a cancer that's so advanced that the entire prostate, and it's got a very aggressive characteristic to the cancer. And those are the men that need a much more invasive type approach. Some of those men may need surgery. Other times they'll need radiation, usually with what's called hormone therapy or medication to lower their testosterone. But that's the extreme end. There's a lot of men who live right in the middle ground. Enough cancer that they more than should be watched, but not so much that we need to use an elephant gun to treat them, right? That middle ground where we can use a precision targeted therapy is where a lot of guys are going to live with their cancer. And the nice thing is that if we take that approach, then we can treat the cancer and preserve their quality of life. So there's a balance here, right? And that's really important. Really important.
Good. Let's take a short break here and listen to an Alzheimer's tip from Dr. Craig Curtis.
We now know that Alzheimer's disease starts about 20 years before the symptoms, with the buildup of a toxic protein called amyloid. And so scientists have been on a quest to remove amyloid to see how it affects the disease. The medicine that was recently FDA approved to slow down symptoms in people with Alzheimer's disease memory problems works by removing this substance called amyloid out of the brain. And now we're attempting to use those medicines to actually remove amyloid before someone develops symptoms of Alzheimer's disease, such as memory loss and forgetfulness.
So that's in that 20-year period before the disease is obvious?
That's right. Scientists now call it Alzheimer's pathologic change versus Alzheimer's disease. And we're saving the term Alzheimer's disease for when someone is actually experiencing symptoms due to Alzheimer's disease.
With over 20 years of experience studying brain health, Dr. Curtis's goal is to educate the Villages community on how to live a longer, healthier life. To learn more, visit his website, craigcurtismd.com, or call 352-500-5252 to attend a free seminar.
I'm back with Dr. Stephen Scionti. What types of different focal therapies are there for prostate cancer, and what makes each one unique?
At the Scionti Prostate Center, I've been involved in doing this sort of work going back to the late 1990s. I did my first focal therapy approach in 1999. And in those days, we used a technology. The first approach was freezing, targeted freezing, or what's called cryotherapy. So the sort of granddaddy of all focal therapies is cryotherapy or freezing. Now, today it's gotten more modernized where you can use that MRI roadmap, but basically we're placing freezing needles through the skin into the prostate to freeze a portion of the prostate. And those freezing needles are connected to a computer which controls the freezing, and it uses a gas called argon, which creates a lot of cold. So that's freezing or cryotherapy. It's a bit invasive because I've got to place several needles into the prostate to get the freezing. But that's the first approach that was developed, and we still use that for appropriate patients. In 2004, we started to see the development of a technology called high-intensity focused ultrasound, or HIFU. In fact, the early research goes back to the mid-90s on that technology. But HIFU is focused ultrasound therapy. So high-intensity focused ultrasound, and the acronym is HIFU. But that's focused sound energy that can be directed from a probe in the rectum, focusing the sound energy to where the tumor is. So it's a focused sound treatment. Now, what does the sound do? The sound creates heat. So we're creating a very intense thermal or heat treatment of the tumor region, again, guided by the MRI guidance. So taking that MRI model I talked about for the biopsy, we can take our model and use that to guide the placement of ultrasound energy through the rectum into the tumor region. That's called focal HIFU treatment. One of the more modern approaches, in fact, the most modern approach to date, is something called TULSA, transurethral ultrasound ablation. Now, this one's really cool because this is a technology done in the MRI machine, in which the MRI is running continuously, taking continuous pictures of the prostate so we can see the tumor region continuously real time. Now, the TULSA procedure delivers the ultrasound energy through the urinary channels, so it's the center of the prostate out. From the center of the prostate out, the energy comes, and it comes out like a radius, or imagine a wheel, and you've got the hub, and the wheel is the direction that the ultrasound energy goes. And we can sweep that through a radius, through a 10-degree, 20-degree, 30-degree arc, whatever we have to sweep that through to cover the tumor area. But the nice thing about that is it's totally non-invasive. There's no punctures. There's a ultrasound probe in the urinary channel like a catheter, right? The MRI is guiding the treatment. There's a lot of AI and robotics involved, but it's a precision, temperature-guided, MRI-guided treatment. And I can treat sometimes a quarter of the prostate, sometimes a half, whatever I need to treat to get the tumor region. But that would be the state-of-the-art treatment today is the TULSA. It's called TULSA Pro. in the area, it's available in our local region over in Wesley Chapel. So we do a lot of work with the BayCare system, and BayCare has a state-of-the-art MRI suite in Wesley Chapel, and that's where we do our TULSA-PRO treatments today.
Mm-hmm.
Fine. Yeah.
I'm curious, how many centers around the country are doing this TULSA-PRO approach, which sounds phenomenal?
About 20, probably. It takes a lot of specialized training, and it takes a very advanced treatment center to do this. There's a lot of complex technology that's going on there. But there's about 20 centers that have active programs in the United States. The nice thing is that a treatment that's done in the hospital environment, like we have at BayCare, for our Medicare patients, we're going to be able to get some insurance coverage, and that's important. If it's not done in a hospital setting, there'll be no insurance coverage at all. But for our Medicare patients, if we're using a hospital center like BayCare, depending on the Medicare type policy someone has, oftentimes we can get some coverage for that patient.
Now, when you say Medicare, you're talking about traditional Medicare or Medicare Advantage?
No, it's traditional Medicare is pretty automatic. That's a great question because most people don't understand the difference. Traditional Medicare, no questions asked, is going to have coverage for TULSA. Medicare Advantage plans are very much individual, and they get to make their own rules, right? And it's arbitrary, right? That's on a very much a case-by-case basis.
Right. So your center is in Tampa area.
My office is in Sarasota. TULSA Center, our TULSA program is all performed at BayCare in Wesley Chapel. Our HIFU procedures, for example, happen here in Sarasota, but our TULSA programs is located at the state-of-the-art center that's a brand new hospital and beautiful MRI center. This is an anesthesia procedure where the patient goes to sleep in the anesthesia machine. So one of the big advantages of a center in a hospital is you've got skilled anesthesiologists who are used to working inside of an MRI suite. It's called an interventional MRI suite. And in the BayCare footprint, they built this beautiful center in Wesley Chapel. So it's a wonderful center for us.
I'm wondering how that compares, because I've been in an MRI machine and they go crazy with you, taking off all the metal off your body. I can't imagine it.
That's the challenge, right? No, that's the challenge. Complicated equipment that has to be compatible in that MRI environment, right? And so it's not any center can do that. Your anesthesia machine's got to be MRI compatible. All the anesthesia monitoring has got to be MRI compatible. And so, yes, you have to have staff that's used to working in the MRI suite because there could be no metal. You're right. No metal at all.
Metal of any kind.
Yeah, no, that's right. If someone came in with a piece of metal in their pocket, that'd be very bad.
Yeah.
It'd go right into the magnet.
Well, people have fillings in their mouths.
Fillings in the mouth are fine. That's not magnetic. But things like, so some of the patients that we got to be careful about is if someone's got a pacemaker, they might not be a good candidate for this procedure because most pacemakers don't work well in an MRI environment. But anyway, that's the most state-of-the-art technique that we have today. So the three main treatments then, to summarize that, we can freeze the area, we can put ultrasound energy from the bottom up, that's HIFU, or in the MRI suite from the inside out under MRI control, that's TULSA. And TULSA would be the most recently introduced process. It was FDA approved in 2019. We've done several hundred of these procedures to date. And I will tell you that they're some of my happiest patients because they've had a non-invasive precision treatment. But you got to be a right candidate. So it all starts with doing the diagnostics the correct way, right? You got to biopsy the prostate the right way. You have to know where the cancer is. You have to understand where it lives in three-dimensional space, how to get energy to that. But if someone's a great candidate for that, it's a tremendous approach for them.
What about patients who've had prostate cancer that spread beyond the prostate?
Yeah, and so that happens, unfortunately, all too often, right? And men like that today, applying treatment just to the prostate, not going to help them. But that story is really different than what it was 20 or 30 years ago. When I was a young doctor, early on in my career, the only option that we had for men like that was a castration operation. They had their testicles removed because if you starved the cancer of testosterone, the cancer would slow down. And that was and there were drugs that did that for years. Today, that is so different. There's so many advanced drugs that can be used that alter how that cancer interacts with the male hormone testosterone. There's different immune therapies today that are available. There's different types of chemotherapy. So whereas years ago, a man who had cancer that had spread throughout his prostate, that was a death sentence. And usually we would say that half the men would be dead in 2 years. That's not true today. We have a lot of men living 5, 10 years and longer with that condition. So that's a very promising area where a lot of new drugs have come along to extend the lives of men with these advanced prostate cancers.
So drugs are the treatment of choice for the prostate cancers that have spread.
They are.
I want to touch that question I asked a little bit earlier, maybe. Who are the best candidates for the MRI-guided treatment of prostate cancer?
The best candidate for that is a man that's got a cancer, number one, that's confined to the prostate, and they've got a cancer that lives in that middle range. We use something called a Gleason score. So these Gleason score 7 patients are a sweet spot. That's that intermediate grade cancer, confined to the prostate. With TULSA, if I have to treat a quarter of the prostate, I can do that. If I have to treat half or 3/4 of the prostate, I can do that. So as long as the prostate is of the proper size and the energy can reach, we can treat those men. Here's the other added benefit. Men who have an enlarged prostate, who have what we call benign prostate enlargement or BPH, also does a beautiful job treating the BPH tissue as well. So the man that's got a combination of an enlarged prostate and prostate cancer, the cancer's confined to the prostate, and he's got an intermediate risk, intermediate grade cancer, TULSA is going to be a great option because we can treat both conditions, the enlargement and the cancer, with a single treatment.
And again, how long have you been doing this?
I did my first TULSA procedure, the first urologist in the United States, by the way, January of 2020, January 2020. We started the program right before COVID, and that first year, 2020, I think we had 66 patients that had TULSA procedure. You know, a lot of patients couldn't see their doctors because of COVID. We were open. We're in Florida, so we were open. We saw patients come from all over the country here to have their cancer treated. But since that time, we've been quite busy with this. I do the TULSA procedures generally about 4 days every month. So I devote 4 days a month to our TULSA program, and our patients come from all over the country. We recently treated a patient that came from Alaska. So we see patients from all over the country here.
So I imagine the machine is very specialized, and there aren't very many hospitals around the country that have it. How many patients do you see? Do you see many patients from the Villages area?
We see plenty of patients from the Villages area, and we see them for patients come down for biopsies, for these precision biopsies, and with all the different focal therapies. But sure, it's not that far. From the Villages to Sarasota is about a 2-hour drive. So it's not bad. A lot of our patients come, again, they've got to fly in, but our Florida patients, it's easy to see us from the Florida area. So this is a program I've been working on for well over 20 years. When we first started this whole concept of focal therapy, people thought we were crazy people because the idea that you could treat a portion of the prostate, technology didn't exist to do that 25 years ago. It didn't exist. And the idea was cancer is always involved with the entire prostate. The problem is in those days, we didn't have MRI. We didn't have good diagnostics, and we didn't have good technology to be able to deliver treatment to a region. So the only thing we could do 25 years ago was take the prostate out or apply radiation to the entire prostate. But today it's different. The diagnostics are different. The ability to localize the cancer is now there. The ability to deliver energy to a region is there. And that's resulted in a tremendous improvement in quality of life for our prostate cancer patients. So what was very controversial 25 years ago now is becoming very popular. And many of the major medical centers around the United States have initiated programs in focal therapy. So where they used to think we were crazy people, now they think we're pretty smart. And so I speak continuously around the United States on these topics at meetings. And if you're ahead of the pack in anything, people think you're a little off, right? They think you're a little nuts.
Well,
but then they begin to think maybe there is something to that. And then eventually they think you're pretty smart. That's how it goes.
yeah, I've seen that before. I had a friend who had the freezing procedure on his half of his prostate, and they wanted them to come back for the second half.
One of the analogies that's been used over the years is an analogy was made to breast cancer. In fact, one of the early terms used for focal therapy was the male lumpectomy. The male lumpectomy. The idea is that in the old days, if a woman had breast cancer, the only option she had was a complete removal of the entire breast. And of course, all the things that go along with that, all the negative consequences that went with that were there.
Complications.
That's right. But as technology improved, there was a realization that if the breast lump could be removed with a safety margin around it, as long as the cancers weren't overly aggressive, women did just as well, and they maintained their normal quality of life. And so the same analogy has been made to prostate cancer. Now, if a few years later, in the other breast, a woman got another lump and they can have another lumpectomy. So the same analogy is there. If we treat a bad area like prostate cancer and maintain function, and we monitor someone periodically with MRI studies, and say 5 years from now, something shows up on the other side of the prostate, we go back and treat that area if it's necessary. But all along, we're maintaining a balance between treating the cancer and maintaining that quality of life. And that's the tightrope that we're always trying to walk. And that's where we got in a lot of trouble years ago with one of the government task force panels saying that prostate cancer is being overtreated. Let's not even bother to diagnose it anymore. So there was a recommendation, if you'll recall, going back about 10 years ago from one of the governmental task force agencies that said, too many PSAs are being done, you're finding too much prostate cancer, overtreating too many patients unnecessarily. The government's, their approach was, let's tell doctors not to do PSAs anymore. So what they did is to use an old saying, they threw out the baby with the bathwater is what they did. The right answer is, let's be smart about who we do a PSA on, and let's be smart about our diagnostics. Let's not treat the people who don't need treatment. That is, do surveillance on the low-risk patients. The patients that need treatment, we can treat focally. Let's treat the bad area. Let's preserve quality of life. And let's reserve those aggressive treatments only for the men that truly need it. Right? So that's the more enlightened approach, I think. And that's where I think the world has come to.
I think that is more enlightened, Dr. Scionti, to find out more or set up an appointment. How do they do that?
Our website's been up and running for well over 10 years now. It's Scionti Prostate Center, Scionti, S-C-I-O-N-T-I, SciontiProstateCenter.com. That's the best way to find us. We have a lot of videos on YouTube explaining a lot of this stuff, but people find us from word of mouth. That's probably the most common way, but we're really easy to find on the web. And we have a way where a patient can fill out an inquiry form and our staff gets back with them really within the hour and gets right back with folks. And they get me records, I review records, and we review patients' cases to see if they're candidates. If they are, then we take the next step and get them in to see me. We do an initial review on anyone that's interested with prostate cancer.
Thanks, Dr. Scionti. And I'm sure you'll be hearing from some of our listeners.
Thank you. I enjoyed the opportunity.
Remember, our next episode will be released next Friday at 9 a.m. Should you want to become a major supporter of the show or have questions, please contact us at mike@rothvoice.com. This is a shout-out for supporters Tweet Coleman, Ed Williams, Duane Romick, Paul Sorgan, and Dr. Craig Curtis at K2 in the Villages. We will be hearing more from Dr. Curtis with short Alzheimer's tips each week. If you know someone who should be on the show, contact us at mike@rothvoice.com. The way our show grows is with your help. Text your friends about this show if you enjoyed listening. Use the fan mail button on our homepage, villagesvitality.life, to leave comments. Be sure to include your name, email, and phone number. We thank everyone for listening. The content of the show is copyrighted by Roth Voice 2026, all rights reserved.